Hello, my name is Vivian Fonseca. I'm from Tulane University in New Orleans, Louisiana. Joining me today is Jonathan Leffert, who's an endocrinologist in Dallas, Texas, and the current president of the American Association of Clinical Endocrinologists. And we're discussing insulin therapy in clinical practice in patients. And I want to discuss with Jonathan a patient. He's a 42-year-old African-American male with a 3-year history of diabetes. He started oral agents, initially did reasonably well, then had to go on to basal insulin because he got very rapid worsening control. Started getting worse quite quickly. He related some of that to stress at work, a very demanding job. He's unpredictable work schedule. He travels a bit. He gets a little tired with this. He's a little frustrated managing his diabetes. His sugars are high fairly frequently, and his A1C is 9.1. You've been trying various medications. You advanced oral therapy fairly quickly. He started on metformin, went on added glimepiride. He's taking metformin 1000 BID, glimepiride 2 BID. He then added linagliptin. He started initially with NPH insulin, changed that to degludec. He takes degludec U200, 40 units at bedtime, but sometimes when he's traveling, he takes it in the morning. He has some flexibility with that, but he's still not getting good control. He's a tall guy, 6 feet. He's 184 pounds, but even because of his height, you work out his BMI, it's 25. So what's your clinical impression?
So Vivian, this man looks like he has classic insulin deficiency, whether he has true type 1 diabetes or has latent diabetes or autoimmune diabetes, or does he have type 2 diabetes with just the progression of the disease to insulin
Fairly
deficiency?
quick, isn't it? 3 years.
Yes. So he might need something like a GAD antibody to determine whether he truly has type 1 diabetes or not.
So just to clarify, GAD is glutamic acid decarboxylase. It's an antibody that doesn't go away like islet cell antibodies go away, and we use it in practice to identify type 1 diabetes. Well, all it tells you is you've got autoimmune disease, where it makes it more likely that somebody has type 1. And about 4 to 5% of people who we think have type 2 actually have these antibodies, and they tend to need insulin a little earlier. This guy, within 3 years, has gone onto insulin, and he's not that obese. He hasn't got the classic features of type 2 diabetes. So.
And if you did find out that he had GAD antibodies and had type 1 diabetes, then the oral agents would be unnecessary in this patient. More than likely, you would switch him just to a basal bolus insulin. If he didn't, then you might continue on some of the medications, most likely stopping the glimepiride, the sulfonylurea in this case.
You raise a very good point. You know, you talk about oral agents being unnecessary. I rarely hear that from people, but yes, metformin is a great drug. It's been used because of the UK PDS data as the first-line therapy in diabetes. But remember, in UK PDS, it was only the obese people who got metformin as monotherapy. This guy's not obese.
Correct. So I think, if you're thinking about how you would sort of go about managing him, I think first you really need to sit down with this gentleman and talk to him about what you're thinking about the sort of type of pathophysiology that he has, and really get him to understand that his insulin deficiency is going to require insulin, and that it's most likely going to require a basal and bolus insulin. And have that conversation, because he's very frustrated with the fact that he's been trying a number of different agents and really nothing has worked. Well, it's not going to work if he doesn't get enough insulin. If you don't have insulin, you need insulin to be able to metabolize the glucose, and he just doesn't have that. So that's going to be an important component of trying to deal with the frustration and onboarding this patient now to what you're going to try to do next, which is more than likely add bolus insulin, you know, on a most likely pre-meal, 3 meal a day if he's taking 3 meals level. So that's a big component of what I do daily in practice. Is I really spend the time to try to allow the patient to really understand where they're going. And I think the compliance of taking insulin goes up tremendously if you get the patient to buy in to the understanding of what they're doing.
I think you're absolutely right. For this guy needs to understand he's taking a good insulin in a fairly reasonable dose for his weight. He probably has type 1 diabetes, as you pointed out. And if he understands that, he's going to take the insulin. And let me ask you, would you stop these oral agents in that case?
Well, certainly if I had the GAD antibodies, I would for sure. If they were negative, then I would certainly stop the glimepiride and start peeling away the oral agents as we were adding the insulin and getting better glycemic control. So again, the whole idea is monitoring, making sure that he is following up with sugars and A1Cs and close care to be able to get this guy into a better range. 9.1 A1C, for one thing, he's not feeling well with that A1C. His energy level is probably decreased. He may be having some hyperglycemic symptoms. I mean, this is sort of in a situation where we really need to take some urgent steps and move forward quickly towards trying to achieve better control.
Just to clarify, we do use oral agents in some people with type 1 diabetes, but it's mainly in those who are obese. This guy is not obese, and I would, I would follow what you just said, gradually taking him off, but putting in prandial. So which prandial would you use? Would you use a regular? Would you use an analog? Or?
Well, I mean, I think that we've talked about the use of analog insulins as being much improved in terms of the time to peak and the ability to have less hypoglycemia. I would certainly use an analog insulin. I would start him out on an analog, and I would use that I would do it based upon insulin to carbohydrate ratios. You could start with a fixed dose depending upon just the ability of the patient to understand all the nuances associated with dietary manipulations and carbohydrate to insulin ratios. But you would want to prepare him if you thought he was a type 1 diabetic for those sorts of processes, because again, down the road you may be even intensifying his insulin regimen even more.
And he's going to need a lot more monitoring than just fasting glucose.
And, yes.
Probably continuous glucose monitoring
yes.
may be an option. I would reassure him that if he felt that the injections were too much, consider a pump or something like that.
Absolutely.
There are a lot of options today for patients like this.
Right. And I think, again, having the conversation initially with him about what his problem is, where he's going with it, what that timeline and what that looks like, I think is crucial towards buying in to all these steps along the way. Patients are managing this disease for themselves. We're the guide, we're the map, but they do the work. And we have to give them the opportunity to do it in a really appropriate way.
I would also bring in the issue of the fact that he's not feeling well, and that if his glycemic control improved, he would feel better.
Absolutely.
It would improve the quality of his life, and despite having to take multiple injections or use a pump, it could very well fit in with his complex work schedule and lifestyle. There are ways to do it, and it shouldn't detract from his ability to do whatever he wants with his life.